happened?
No gag, no gag
Glossopharyngeal
reflex.
glossopharyngeal nerve is involved here because the posterior pharyngeal wall is affected and the gag reflex is also absent. So the
Yes.
glossopharyngeal nerve arises from medulla.
oblongata, yes.
Mhm. Yes.
Yeah. Again, another way of kind of memorizing cardiopulmonary resuscitation, medulla oblongata, it helps in the the breathing and all of that. So during those moments when the patient is unconscious and he cannot be revived, most likely dysfunction of the medulla oblongata occurs. All right. And again, another giveaway was absent of the gag reflex. We discussed in the earlier lecture that how glossopharyngeal nerve, it supplies the gag reflex, and therefore, whenever we have an absent gag reflex, it's suspicious for the dysfunction of the medulla oblongata. Again, prolonged anoxing period. This is concerning for brain death. Okay, what do you do if the patient is brain dead? Do you keep them on ventilator or not? They're
No,
they're no,
no, yes.
why
Or leave
not?
him
But
on ventilator.
they have a heart that's running and they're alive, but they're brain dead. What do you do? Do you pull the plug or no?
Depends upon like
No,
consent from the patient's
donor.
relatives or something. It's a ethics
Depend
Because
on
question.
the
Yes.
they can
depend
be
on the local
too.
guidelines from state to state in US.
Okay, so brain death is the legal death in medical terms. In medical dictionary, whenever we have a patient who is brain dead in America, you are not obliged to inform the parents or the child or the spouse or whatever. You can pull the plug. You can get them off the ventilator because that is the meaning of actual death. You will not be held accountable if you pulled the plug, because medically you can do that and it's allowed in United States of America. All right. The gag reflex, we talked about that, how it's mediated by the glossopharyngeal nerve. An absent gag reflex means medulla oblongata dysfunction. So again, root memorization question. Okay, then we have MRI of the brain. So first, let's see what's happening on the MRI. What's wrong in the MRI? What is this?
These are the serpiginous
Infarction.
low intensity serpiginous areas which showing the AV malformation.
Infection.
AV
Okay.
Mm.
malformation.
So we can see from the vignette there is 15-year-old girl evaluated for recurrent episodes of focal onset seizures. She had bilateral tonic-clonic seizures. She's also had headaches. Patient has no prior medical condition. MRI of the brain is shown. Which of the following histopathological findings? Again, I'm putting it again. So what do you think this is?
This is circular dilatation in the medial in the cerebral
Cortex.
hemisphere. Yeah, cortex, which indicate that there will be maybe some arteriovenous malformations.
Yes.
AV
Yes.
malformations again are a common cause of seizures. You see patients having seizures because of that. So what do you think the answer is?
Yes. It will be the tangel of large blood vessels
Mhm.
with thickened walls.
Yeah.
Yes. So
And
that
it
was
yes.
C. So these were the abnormal tangle of the vessels, dark flow voids. Infarctions do not look like that. All right. If you have seen an ischemic infarct, they are like homogeneous and they're like blackish, dark black in nature. If you see that, blood is usually white in color. So if you kind of see a mixture of both of them, you see that there's some whitening going on and there's some black hole type, then that means these are AV malformations that are occurring. Where do you see AV malformations?
In liver.
Okay. So AV malformations are vascular malformations. We know they're like kind of like the blood is going from arteries to veins, and we can see that in the MR. So even if we don't know what's happening, we can see that these are the AV malformations over here. They're again a common cause of seizures as well in patients. And if they rupture, then you may have there's something called as intracranial hemorrhage or subarachnoid hemorrhage. We're familiar with what SAH is, right? And they appear like a bag of worms. So if you can kind of go back and see that the picture is like a bag of worm, you can see it's like, you know, a scribbled and it's all blackish and whitish. So that's a nice segue of remembering that these are the AV malformations. Okay, why wasn't it A? Why wasn't it A? What's A?
This is lymphoma. CNS lymphoma.
Exactly. So I want to see you how CNS lymphomas are. All right. So these are the lymphoid cells. Again, this is not a picture of a lymphoma. Lymphoma is usually like a circle type presentation, right? You do not see a circle type presentation over here. It's usually circumscribed, and it's like a circle type enhancing lesion where you can see whose mic is on. I think somebody's mic is on. All right, see, you can see that is a circumscribed lesion. It's an enhancing lesion. This is a CNS lymphoma. How do you who
I
who
think
is
it's Amit.
your
Amit.
mic is on?
Okay.
Your mic is on. All right. How do you differentiate between CNS lymphoma and toxoplasmosis? How? Because they both present with circles and circles. How do you present? How do you differentiate?
I think
Toxoplasmosis has multiple ring enhancing regions.
ring enhanced
Yeah,
lesions.
ring enhancing lesion in the toxoplasmosis.
Toxoplasmosis can also look like this. How do you differentiate between toxo and CNS?
Multiple.
On the basis of the location, most of the times the toxoplasmosis are over here. They
Or
have
calcified calcification.
they have periventricular lesions, like they will be present over here. So on the basis of the location, you can like kind of differentiate. And also by the number, like in toxoplasmosis there will be multiple. Usually CNS lymphomas are singular. They can be, so they are very confusing on the NBME, the CNS lymphoma or tox, but the location is very important. If it's like near the ventricles, and that means they're talking about tox. If it is like a little bit upwards and a little bit away from the ventricles, and that means it's CNS lymphoma. All right. Okay, so we talked about that. Yeah, see, again, toxoplasmosis. All right, see, you see how they're also like lesions like this. So sometimes on the NBME, it gets very, very confusing to differentiate between tox and CNS lymphoma, because they kind of have this circular imaging, and on a black and white picture, it's really hard for us to differentiate. So that was an interesting differentiation that I told you guys, that the tox is usually found near the ventricles, and CNS lymphomas are a little bit away from the ventricles. All right. Okay, I think we're done with this question. Next question, guys. All right. So vertical eye movements are intact, but horizontal eye movements are impaired. There's loss of motor strength in the upper and lower extremities bilaterally. Ischemic infarction from cocaine-induced vasospasm is suspected. A lesion involving which of the brain regions is the most likely cause of the patient's current condition? So a 56-year-old man, due to weakness and difficulty speaking, he has hypertension, cigarette smoking and polysubstance use, headache. All right. Okay, so what's happening?
There is bilateral upper and lower limb motor loss. So it's locked-in syndrome.
All right. Anybody else?
Yes, it's locked in syndrome.
What
Yes.
part does it affect?
The ventral pons.
Ventral pons.
Points.
Pons, yes. So this is a locked-in syndrome. We know that in the locked-in syndrome, the vertical gaze is preserved. All right, you can look vertically, but you cannot look horizontally. There's also loss of motor function. So this is known as a locked-in syndrome. It is due the infarction of the bilateral ventral pons, and it causes quadriplegia, again loss of speech. There are absent horizontal movements, eye movements. There is preserved sensation, all right, and it occurs due to the damage of the ventral pons. All right, okay, another thing, Wallenberg, we know, right? We discussed Wallenberg. What happens in Wallenberg?
There will be a loss of sensation on one side of the face, the side of the lesion,
Yeah,
and there will be absence of the sensation and in the other side of the body, upper limbs and lower limbs. Will
exactly. So in Wallenberg, we know pica gets involved. There's diminished gag reflex, contralateral loss of pain and temperature. There is also ipsilateral loss of facial pain. Then you have vertigo, diplopia. Again, very high yield. Wallenberg is very important for you to remember. They don't ask Westman syndrome. No need to remember that. But they do ask Lockton syndrome and they do ask Wallenberg syndrome. Again, two high yield things over here. All right. Next question we have, what's this? What's happening? What's happening?
the bones. This is the bones.
Pons
Maybe
is
there is
getting to
inside
affect
it.
the
All right, so this is the pons. What's happening in the pons?
Maybe there is hemorrhage
Demyelination.
or
could be
demyelination.
demyelination, could be hemorrhage, because it is the low intensity lesion in the pons. Could be
Mm-hmm.
pontine hemorrhages, could be pontine demyelination.
It could be infarction as well, right?
Yes, and
So
infarction.
we can see that this 12-year-old boy evaluated for worsening headaches for the past several months, paresthesia, weakness, and stiffness of the extremities. MRI reveals an expansile mass in the lower pons as shown in the image. Which of the following is most likely be observed in the patient due to direct involvement of cranial nerve nuclei by the brain lesion? What do you think is going to happen?
In the bones, there will be the cranial nerves, five,
We can
six,
rule out
seven,
Yeah,
five,
why?
six, seven.
Okay. Is it asymmetrical pupils?
no because it's third cranial nerve.
No,
All right. Is it spontaneous nystagmus?
no.
All right. Is it tongue atrophy?
No.
No.
Mm,
Is it
No.
trapezius weakness?
Accessory, no.
Then we're left with vertical diplopia. Let's see if we were right or we were wrong. So it was spontaneous nystagmus. We were wrong. It's a pontine glioma. Oh, interesting. I haven't seen this sort of question, but okay. So yeah. So this is the midbrain. We know that this is the pons. This is the medulla oblongata, right? This comprises of the brain stem. We're familiar with that. And they're saying that there is a pontine glioma. It's a tumor in the pons. All right. The patient has a mass, which means it's a tumor. Inferior pons, pontine glioma. Okay. So the vestibular portion of the cranial nerve 8 conveys information about head position and movement and is involved in the vestibulo-ocular reflex, which stabilizes the gait during head movement. Therefore, damage to the vestibular nuclei of cranial nerve 8, it can lead to nystagmus due to impairment of the VOR. Now, why isn't it vertical diplopia? Vertical diplopia can occur with the damage of the nucleus of the trochlear nerve, all right, which innervates the SO4, we know that superior oblique cranial nerve 4, that's trochlear, or the oculomotor nucleus. Both nuclei are located in the midbrain. All right, so it's saying that the vertical diplopia, it is occurring due to the trochlear nerve and oculomotor nerve dysfunction, and both of those nuclei are present within the midbrain. They're not present in the pons because it's a pontine mass sort of thing. That is why it's spontaneous nystagmus, because cranial nerve 8's nuclei is present within the pons. That's what they're asking. All right. Is it clear to you guys? Again, I haven't seen this sort of question ever. This is my first time seeing this question. So it's okay if you guys got it wrong. It's okay. All right. Is it clear?
Yes,
Okay.
doc. Yes, doc.
Okay, next question. Okay, cardiac examination is within normal limits. Lungs are clear to auscultation. Bilateral lower extremities have 2+ pitting edema to the mid shin. Okay, compared to healthy non-pregnant women, which of the following parameters is most likely to be decreased? So we have a 38-year-old woman, gravida 1, 34 weeks gestation. She has increased swelling. Okay, the patient noticed the swelling a few weeks ago, but now she cannot stand for more than an hour without needing to elevate her legs. She has no orthopnea, dyspnea, or chest pain. She's not eclamptic. What do you think is wrong?
All the other parameters get increased, only the systemic vascular resistance decrease in the pregnancy. They have asked which parameter is decreased here. So the
Yeah.
cardiac preload increase, cardiac output also increase, central venous pressure and the plasma volume also increase. So only the factor which decrease is the systemic vascular resistance.
Exactly.
Yeah.
So we know that cardiac output and SVR kind of go opposite in direction, right? So if cardiac output is increasing, we know SVR is going to decrease. Again, why all of them are increasing? Because the patient has one more baby to take care of within her body. So that is why all of them get increased to compensate for the increasing fetus size. Cardiac output and SVR go opposite in directions. So if cardiac output is going to increase, then SVR is going to decrease. All right. So in respiratory volume, again, tidal volume is gonna increase. There's peripheral edema. There's minimal edema in patients who are pregnant. That is why they'll sometimes appear a little swollen as well. All right. I don't think it was a neurology question, but it somehow popped up. Okay. So we know that already. I'm not gonna discuss it. Okay. Then we have the next question. There's this 32-year-old woman, worsening headache and double vision. Patient reports no chronic medical condition but has had nasal discharge for the past several days. Physical examination shows weakness of the muscle shown on the below CT scan. Okay, so they're saying that this is the muscle that's getting weakened. What is this muscle called? What's this muscle?
I think it's
Lateral
lateral, yeah.
Rectus, yeah.
It's supplied by the abducens nerve. We know that, right? Okay. So pleural discharge, again, blah, blah, blah. So we know that that's a lateral rectus. It's going to get supplied with adducens nerve. Yeah, again, nothing to kind of tell what's happening. It's just a picture-based question. If we kind of like zoom this on, we can see that this is the lateral rectus. This is the superior rectus muscle, and this is the medial rectus muscle. This is superior oblique, the blue line you can see over here. And this is the inferior rectus. It's kind of a little bit downwards. So if you're familiar with the pictorial representation of the muscles of the eye, then it kind of becomes really easy for you to grasp on it. Okay. Next question. What's happening? Evaluation reveals a large amount of stool in the distal column due to impaired motor function. Anal sphincter tone is decreased. Okay, so we have a 32-year-old man evaluated for bowel dysfunction. Patient suffered multiple injuries. He was hospitalized for a very long time. Since the injury, the patient developed severe constipation and fecal incontinence. What do you think the answer is? He is having absent, function in the distal part of the colon.
Yeah, that's due to absence of the S234, which is the sacral spinal innervation to the external anal sphincter.
Okay,
So
so what do you?
C.
C.
We all agree with C? Yeah, so we know that pelvic autonomic nerves is sometimes get injured due to, in operations. And when sometimes they do get injured, then we have a lot of problems in defecation. That's supplied by the anal sphincter, supplied by the S2, S4, and external sphincter, which includes the skeletal muscles. It is the voluntary control. We know that. Internal sphincter, it is not in the voluntary control. All right. And yeah, so the external sphincter is supplied by the pudendal nerve, S2, S4, And the internal sphincter, it is supplied by what? By the pelvic splanchnic nerves to relax the sphincter. So because the patient has impairment of both, which means he has an impairment of the external as well as the internal, and that is why in collection there's something happening within the sacrospinal cord. It is the conus medullaris damage, and that is why the patient has impaired peristalsis of the anal canal, and that's why he's having fecal incontinence. All right. Again, I don't think that something needs to be explained over here. Again, root memorization question. All right, what's this A part?
Is
This
the
is the
cortex.
gyrus. The gyrus.
Central gyrus.
Central gyrus.
Okay,
Yeah.
what's C?
C is the cerebellum.
Cerebellum.
Okay, what is B?
B is the
Midbrain.
midbrain.
Midbrain. Pons.
D pons and E medulla.
E is the medulla. All right.
Medulla.
Okay. Okay, so if we kind of read on the question, there's a 64-year-old man, history of uncontrolled hypertension, and blood pressure is really high. Examination shows left facial weakness affecting the forehead and lower face. Muscle strength is 3/5. What do you mean by, how do you see that the muscle strength is 3/5, 4/5, or 5/5?
It's
Uh,
the
By
power.
that,
Power of the
5/5 is the full strength. 4/5 is the mildly reduced and then moderately reduced.
Mm-hmm.
If you
3/5.
exert pressure against
Very
pressure.
good. Very good. All right. So what's happening? DTR are brisk and Babinski sign is present on the right. A midline sagittal section of a normal brain is shown below. The patient's lesion is most likely located which of the following anatomical locations? What do you think the answer? So we have left facial weakness affecting the forehead and lower face, and DTRs are brisk, and the Babinski is present on the right.
maybe
So,
D.
since in
this is well done.
facial nerve, since there is dual
Pons.
supply from the forehead. So, if forehead is involved, then it means lower motor neuron lesion. So, there will be lesion of the facial nerve. Facial nerve involved. Facial nerve nucleus will be involved.
Yeah, because of the
This is the
positive
lower motor
Babinski
neuron
sign, it's,
lesion of the facial
I
nerve.
think it's D, the Pons.
D.
Yes.
Yes.
So everybody occurs with the answer D. Let us see, are we right or are we right? Yes, we were right. So if we kind of go through that this is the cortex. We know this is cerebellum, midbrain, pons, medulla. They make up the brain stem. We know about that. All right, the patient has risk factors for stroke. Again, the patient has very high blood pressure, so kind of gives us that, all right, hypertensive patient came in because of a stroke. Cross signs of right arm and leg weakness consisted with an upper motor neuron pattern, which means, so whenever you have upper motor neuron weakness, it's everything goes up, and when you have a lower motor neuron, then everything goes down. All right, you have hyperflexia, upgoing Babinski in the upper, and in the lower motor, what happens? Lower motor neuron.
Fasciculation,
Lower tone, lower
fasciculation, absent of reflex.
musculation, yes.
Hyperflex.
Hyporeflexia. What sort of paralysis occurs in lower motor neuron lesions?
Placid.
Flaccid.
Flaccid paralysis.
Flaccid.
Very good. Flaccid paralysis. Okay, so we know that the facial nerve, it originates in the pons. Lesions above the pon lead to an upper motor neuron pattern of a facial weakness. Lesion at the level of the pon result in a lower motor neuron pattern. Therefore, the patient's lesion is likely in the left pons, resulting in a contralateral right arm and leg weakness with ipsilateral left facial nerve palsy. All right. Okay. I just want to go through this so that you're familiar with that. Okay, not important, not relevant. All right. Okay. Next question. Okay, so the DTRs or reflexes are 3 plus on the right and 2 plus on the left. Rovinsky sign is present on the right and absent on the left. There is no ataxia. Sensation is intact. Which of the following is most likely location of the patient's lesion? So we have a 70-year-old man brought to the ED after right-sided weakness and double vision. Medical history is significant for type 2 DM. Blood pressure is very high. Okay, speech is normal. On examination, the left eye has ptosis and is fixed in the outer position and the pupil is dilated. Okay, so what do you think is happening?
Heart cranial nerve
It's,
involvement.
yes, midbrain. It's
Third cranial nerve.
Oculomotor nerve. Oculomotor nerve is getting involved.
infarction.
Mhm.
All right. So if we kind of just, kind of zoom into it a little bit, we will know that what's happening. All right. Contralateral right cortical signs are visual, aphasia, neglect, sensory. We know that they also have, if they're midbrain lesions, we have ipsilateral left cranial nerve palsy. You have a down and out pupil. All right. Cranial nerve 12, it's tongue deviation to the left is present at the level of the medulla. Again, I hate these types of questions. I don't know why. Do you guys hate it too?
Yeah.
Or is it just me? I hate these types of questions.
Yes, we hate to.
I want them to be obliterated from USMLE. Why are they even asking? How would we know? Okay. So Weber syndrome is something that I want you to remember. All right. Okay. So let's just go through what Weber syndrome is. Okay, so cranial nerve 3 originates in the midbrain of the brainstem. We know about that. Left cranial nerve 3 palsy with contralateral arm and leg weakness is most likely caused by the left midbrain infarction due to occlusion of the mesencephalic branches of the posterior cerebral artery. That's called as the Weber syndrome. All right, this syndrome is important. It gets tested. This can develop from obstruction of perforating arteries of the basilar bifurcation. Again, this paragraph is really important if you kind of go through that. Remember that Weber syndrome, whenever you're having, left cranial nerve 3 palsy along with contralateral arm and leg weakness. All right, that's always Weber syndrome. Okay, if we kind of go down, again, same thing what we discussed earlier, it results in the Weber syndrome, ipsilateral oculomotor nerve dysfunction accompanied by contralateral hemiparesis. So what do you mean by Weber? What's Weber's? Ipsilateral oculomotor dysfunction and contralateral hemiparesis.
Yes, contralateral leg and the arm weakness.
Okay, when the patient's asked to stick out, his tongue deviates to the left. What's happening?
The side of the lesion on the left, and this is the hypoglossal nerve.
Hypoglossal.
Hypoglossal, yeah.
Hypoglossal nerve.
And the hypoglossal, which in the
Medial medulla.
in the
It's in the
medulla,
medial.
yes, in the medial medulla.
So what is the
Because it's-
answer?
Left medial medulla, B.
Medulla, yes, BB.
Because the lesion is the ipsilateral.
Yes,
Tongue is deviating ipsilateral, so B. B will be the answer.
yeah. Thank you.
All right. Yes, it will be the left medial medulla. We know that hypoglossal lesions are always ipsilateral. We studied that in the previous question as well. You can see that over here. These are the ipsilateral lesions, and these are the contralateral lesions. Again, hate this type of question. All right. Oh, actual brain. Again, we discussed that. So I'm not going to go through that. What are they asking? They are asking, we have a 65-year-old man. History of AFib, comes to the office with the numbness of his left hand for the past 3 weeks. All right. Eyes are closed. He's unable to recognize the letters written on his left hand with a stylus. What is this called? Unable to recognize the letters.
Stylo.
Agraphia. Agraphia.
Agraphia.
Agraphia is regulated by what?
It is the sensory motor cortex is
So what
involved.
is
Yes, that is the it is sensory
B.
motor cortex is behind the central
Behind the
sulcus.
central gyrus.
So it
So
is the A, post central gyrus.
Yes.
all right? It's the A. Let us see if we were right or if we were right. Okay, yeah, we were right. So that's a normal growth brain. If we can kind of zoom into it, we can see that this is a central This is the central sulcus. This is the central sulcus. You can see that, right? This is the precentral gyrus. That is the postcentral gyrus. That's the frontal field. This is the occipital cortex. Again, unable to recognize the letters. It's that sign is called as agraphia, and it usually occurs due to a lesion in the postcentral gyrus. All right. So we're going to do the last question for today. You guys are doing great. Good job. Okay. Pain and temperature sensations are decreased over the left side of the face, and the direct corneal reflex is absent on the left. Pain and temperature are also decreased over the right side of the body. Sorry. So many alarms. All right. Pain and temperature are also decreased over the right side of the body. Muscle strength is 5 on 5 in all 4 extremities with normal deep tendon reflexes. Which of the following is most likely cause the patient's asymmetrical pupils? All right. So we have a 65-year-old man, hypertension, sudden onset, vertigo, dizziness, physical examination, ptosis, and pupillary constriction. Extraocular movements are normal. What do you think is happening?
This patient have
Horner syndrome.
ptosis and pupillary constriction. Yes. So it could be impaired sympathetic activity.
Yeah, E. Impaired sympathetic activity.
All right, so we are all seeing E. Yes, it was impaired sympathetic activity. Why? Because we talked about that ptosis, meiosis, they indicate, impaired sympathetic activity. That's also called Horner syndrome. Again, in what condition do we see Horner syndrome? In what conditions do we see Horner syndrome?
Lateral medullary syndrome. Yes, you can see it there.
And what else? Do we see them in Pancoast tumors?
Yes, in Pancoast tumor, yeah.
Yes, yes.
Yes, Pancoast tumor. Yes.
Yes. Okay, so we can see them in any sort of injuries, vascular problems. Most likely, they're usually seen with Pancoast tumors. All right, they can also be seen with any sort of Hodgkin's disease if there's lymphadenopathy that's happening, mandibular tooth abscesses. You can also see that with them as well. And yeah, that concludes our module for today. And yeah, so do you guys have any questions for me? You guys can ask, and Dr. Ahmad will take over. Yes, Dr. Rauf, I see that you have your hand raised.
Yes, ma'am. Actually, I don't have a question. I just wanted to just, wish you the best of luck. I think 70 students on order are actually praying for you. You will inshallah make on Monday.
Thank you, guys. I will be more than happy to celebrate with you guys on Monday if I match. And if I don't match, nobody's gonna text me on that day. I will be crying on that day. So do not text me on that day. I'll myself share what happened. And good job, guys. I'm seeing the chat. Yes, Dr. Nahi, do you have any question for me? Dr. Nahi, yeah.
Yes, Dr. Maheen.
Yeah.
Yes, I have a question. We are at the Neuro system right now, but there are too much things as you have gone through it for 15, 16 questions. We are all being together and we have done it, for example. But when you're doing individually, how we should go fast and which things we have to, as you were, the way that you have done, we should do the same way for our individual, for the rest of the Neuro. But because in this way, we are not able to go through each and everything. And there are many things we have to go through it. Yeah, for each explanation, for each question. What you're advising us?
Yeah, so I mean, start with doing 40 questions a day, do one block daily, make it a habit. If not one block, if you find one block a little bit difficult, then start with 20 questions, but try to do one block daily. And again, I said the more questions you practice, the more it's going to stick, because sometimes questions help us in memorization of the answer as well. So that is one advice I will give you, that try to focus on solving more questions and giving it more time.
Okay, thank you. But my question is about this Neuro system specific. About this, but there are many things we have to go through each and every, or the way that you have gone through.
Dr. Ahmad will walk you through it. He's giving lectures on it, I think, daily, and I think he can help you with that. So I think it's more of a Dr. Ahmad question. Dr. Ahmad, are you here? I think he's not here, but it was more of a question.
Sure, muted.
Okay, so I think Dr. Ahmed is sick today, so he won't be joining us today. You guys can leave the session, and there won't be any class today as Dr. Ahmed is feeling sick today. He will